Well, thank you very much. After that really lucid talk and, looking beyond IOP as well as holistic management, my task actually becomes much, much simpler. I'm going to talk about whether tafluprost is a value add in the medical management of glaucoma. These are my disclosures. So, tafluprost is another PG analog, and quite often I get this question because it's the same mode of action by increasing outflow through the uveoscleral pathway. Do we really need another one? By the way, the trabecular outflow, I feel, the function is a little ambiguous. I feel it's not proven. So yes, this question, occurs repeatedly. Do we need another PG analog? Please note that the BAK concentration or the benzalkonium chloride concentration is a lot less compared to other available, and we'll come to that in a minute, leading brand prostaglandin analogs. So just stepping back a little bit and perhaps summarizing what Shibal has been saying, what are the desirable characteristics of an anti-glaucoma medication? Is of course reduction of IOP, and it should be comparable to the current gold standard. And when we're talking about gold standard, we're no longer only talking about beta blockers. We're talking about prostaglandin analogs. They should have long-term IOP control and 24-hour IOP control with minimum dosing and preservation of visual fields, and effective in all or most etiologies of glaucoma. And effective when administered not only in treatment-naive eyes which have not received any medication before, but also when you're switching as well as add-on therapies. Where safety and tolerability is concerned, it has to be gentle to the ocular surface. Remember, Shibal told you they are asymptomatic. I mean, it is reiterated again and again. They are asymptomatic patients, and in case they have side effects, you are actually giving them a symptom. Okay, should not have any serious side effects equally, minimal systemic side effects. So you know that in the older age group, your beta blockers can do that. So therefore, what I'm trying to say that a balance has to be reached between efficacy and safety to help control glaucoma by least interference in the patient's quality of life. And this is what ensures persistence and adherence. Again, a concept that Shibal talked about very eloquently. So where tafluprost is concerned, it actually came into the market pretty early, 2012, but we didn't get the benefit of this drug until 2019. And approvals were granted based on several clinical trials. I picked up two. One where a 24-month phase 3 trial was done on over 530 patients, and it established non-inferiority of tafluprost, and the rate of hyperemia was much less. On the other hand, there was another one which pitted it against the beta blocker. Again, it turned out trumps. So just a brief concept about the studies that have been done, which have proven the efficacy and also safety of tafluprost. This first one tells you that there is effective 24-hour IOP control. This occurred over every single time point that the IOP was measured. There was a blunting of the maximum IOP, minimum IOP, mean diurnal IOP, and range of variation of diurnal IOP. Please remember, diurnal IOP is extremely important. Fluctuation is extremely important. And IOP lowering effect was not very different to the existing PG analogs, travoprost and latanoprost. And what's more, a long-term IOP lowering study that was done over 4,000 eyes and over 2 years found that it was effective in most etiologies of glaucoma, at least the primary etiologies of glaucoma. And adverse reactions did occur in about 18% individuals, and this was not very different from what you expect in PG analogs, including eyelash changes, hypertrichosis, and iris or even periocular hyperpigmentation. Okay, then tafluprost also demonstrated very effective IOP lowering, in all 3 categories of treatment naive, switch therapy, as well as add-on therapies in eyes that it was administered. But we're all worried about this kind of an appearance of a patient. Remember, the patient comes with you with white eyes, and you give this to the patient. Not only is the patient worried, but all his caregivers, his friends, his family are worried. So what is it? Is it the molecule, or is it the back concentration, BKC concentration, that matters? Remembering that tafluprost has 0.001% of BKC. Leading brands of latanoprost and bimatoprost have 0.02, and travoprost at the moment does not have BKC. And I'm talking about the leading brands. Okay, there was a study that was done, and a special software was devised to binarize the digital images that were captured of the conjunctiva, bulbar conjunctiva, to look for hyperemia, and automatically calculated. And patients who were using tafluprost experienced significantly lower levels of conjunctival hyperemia compared to other prostaglandin analogs. So here we are. I'm showing you a few more examples here in this JOAG patient. Now, he's a young patient, but tends to look much older, and that is because of this loss of orbital fat. So you tend to get an orbitopathy. The left eye is still red, right eye less so, because now he's had surgery. You can see there are some signs of surgery still there. This is only 2-3 weeks post-op. But you can see the significant change once the prostaglandin analog, particular type, was stopped in this gentleman's eyes. You can see the deep sulcus, you can see the loss of orbital fat, both sides, you can see the hyperpigmentation, you can see the hypertrichosis. And it's not just this that I'm worried about with certain side effects of prostaglandin analogs. It's also, this is yet another JOAG patient, and you can see that in his 30s, this young gentleman, I'm not able to pull his lids down. So there is tightening, cicatrization also that takes place in these, as a side effect in these eyes. So deep upper eyelid sulcus, or dews as it is called. And here, of course, because the studies were done in Oriental race, you may not, what should I say? Agree with what you see in Indian eyes, but I've just shown you these examples where you see that the same effect takes place in a different way. Look at this young lady, very smart. She was, when she first came to me, she was a student at ISB, and yet with the use of prostaglandin analog, she looks way beyond her 23 years. She discontinued all anti-glaucoma medication in the left eye, where you can see she's got a squint as well because of poor vision. But the changes are not that different. You see, they don't reverse. This is 4 years after her cataract surgery, trabeculectomy filtration surgery in the left eye. So tafluprost, saflotan, was launched in 2019. I had the privilege of being a part of that team. And since then, of course, we've had 2 waves of pandemic. So there have been lots of issues related to its availability, unfortunately, especially in tier 2, tier 3 cities. And so, WhatsApp consultations, video consultations, telemedicine, whatever you want to say it, I've had to reverse quite a few tafluprost applications to other prostaglandinols. Yet I do have fair amount of data. I want to present it to you. It is by no means a clinical trial. It is what we call real world experience. So here I have 44 eyes, and I have deliberately only chosen those that had more than 6 months of follow-up. And not only that, I looked at only the ones that were administered in treatment naive eyes or switch. When you add on, things become a little bit more messy. And so I have deliberately left those eyes out of this particular analysis. So I had 23 treatment naive eyes, and they have a mean follow-up of above 8 months, and a switch for 21 eyes. Sorry, not 21, 23 eyes. So intraclass PGA switch was occurred in 8 eyes. A fixed drug combination of beta blocker and alpha adrenergic, another 8 eyes, and alpha adrenergic and carbonic anhydrase inhibitor 3, alpha adrenergic alone 2. These were the reasons for switch: inadequate IOP control, or red irritable eyes, or a combination of both, as well as a few where I wanted to change over to a single agent. So let's have a look at the etiology, and overriding is open angle disease with POAG, NTG accounting for greater than 50%. Where the total number of eyes is concerned, the maximum IOP untreated, maximum IOP recorded was 20.5. That was in treatment naive, but where the switch was taking place, obviously it was the maximum treated IOP. Post saflotan, this came down to 15.8 and a percentage decrease of 23. That this is both considering treatment naive as well as switch eyes. When you look at treatment naive eyes as a separate analysis, you can see that the maximum IOP was a little bit higher, and I achieved 34% decrease in IOP. When switch was concerned, the percentage decrease was in addition to what was already took place with the medication that the patient was on before. And as you can see, all of this was statistically significant. So just to summarize the treatment naive eyes, sorry, again, because I added another 2 eyes, the slide does not reflect that, but the decrease was by 34%, and all reported comfort with eye drops. And I did ask leading questions, and I had to, because I wanted to know about side effects, and I did not detect any significant hyperemia. Where switch is concerned, I got additional 22% decrease, and all reported either comfort or a decrease in the use of lubricants. Adverse events, 3 eyes reported kajal-like, not 3 eyes, sorry, 3 patients reported kajal-like darkening of the lower eyelid margin, but there was no complaint of increased hyperemia. All 3 patients declined photographs, so I can't show it to you, I'm really sorry. However, all reported comfort and or decrease in use of lubricants, and there was no withdrawal of the drug due to side effects. And withdrawal, as I was telling you, was only in the form of unavoidable switch due to non-availability of the drug, especially during the 2 very troublesome phases of the pandemic that we are going through. So I'd like to share with you 3 cases which I feel tend to emphasize the balance that we need to achieve, and how we can manage these glaucoma patients. A rather disturbing case this was for me. A 50-year-old gentleman who underwent clear lens extraction elsewhere 2 years ago, and at the time had 20/20 vision. This is documented, but was complaining of deteriorating vision. When the patient went back to the treating hospital, IOP, prostaglandin analog was started, but he complained of hyperemia and irritation. And when he came to me, presented to me, the pressure was 18 and 17 on an average CCT. Now remember, he underwent clear lens extraction due to high myopia. And so an average CCT is very useful. At least he does not have thin cornea. And of course, he had open angles. And when you look at the fundus, you can see the very cuptus, which was probably missed. Also, the chorioretinal atrophy, which is very common in myopia. So this was his visual field in February 2019, done elsewhere when PGA was commenced. And you can see that the right, as you noted, the right disc was more cupped and the right visual field was affected much more. And when you looked at 10-2, it was quite worrisome. When he came to me, these were the fields. They looked much worse in October 2019, when he had a pressure of 18 and 70 on the prostaglandin analog. And his untreated maximum IOP was 19 and 21 on an average CCT, as I told you. So here now we still have 20/20 vision, but obviously he's complaining about the quality of that vision because his peripheral visual field is way, way worse, as you can see with the central 10-2 there. So here is when I switched him to Saflotan, and I took his pressure different times of the day, and I found it not going beyond 15 millimeter mercury. Here we are, his visual field. About a year later, you can see that it looks slightly better, or, I don't think visual fields get better. He's definitely stable, and he's happy in the sense that he has the confidence now that things will probably not worsen from here on. His IOP continues to be stable at 2 years. He's a little bit reluctant to have visual fields done in this pandemic, so we are waiting for a repeat visual field. Here's another case of a 75-year-old pseudophakic general physician now. He has known hundreds of allergies. He had red eyes with difficulty in reading, so he was initially diagnosed as conjunctivitis and was started on antibiotics and lubricants, and quite a few of them. But he complained of increased redness, watering, and difficulty in reading. Subsequently, he was diagnosed as glaucoma before he came to me, and his untreated maximum IOP was 22 and 32 with an average CCT. He was put on Simbrinza, which is a combination of alpha-adrenergic and brinzolamide, and he used it only for 4 days when he presented to me. His visual fields looked something like this. The glaucoma was much more advanced in the eye that had higher IOP. And on presentation, his visual acuity was 20/30 and 20/40. And his pressures were 19 and 21 on the medication that he was on. He was so upset and so much in anguish that I could not suggest taking a photograph at that time, but these are my clinical notes that not only did he have quite significant congestion, but he also had follicles, and his discs, they did correlate with the visual fields that we saw. So my diagnosis at the stage was an open angle glaucoma, whether it was pseudophakic or open angle, is immaterial. And I wondered whether he was actually having BAK allergy. So I discontinued everything and put him on Saflotan S. For those who are unaware or do not know what Saflotan S is, it is basically a preservative-free, completely preservative-free formulation, which comes in units in a pack, which has 30 unims, 10 each, 3 packs of 10 each. You need to tear one off, open the top, and apply the medication. It's pretty simple. You do have to put it in, store it as in the refrigerator. So this is when he came back, and you can see he still had hyperemia. He still had follicles, but a week later, it was a lot better. I would say he was 75% better, and his intraocular pressure too was a lot better, 12 and 15 in the right and left eye. And when he was put on Saflotan S, he improved much quicker. So this is how he looks, or looked a few weeks later. You can see that the eyes are much less red. So with this patient, his last visit, IOP was 11 and 15. His complaints of increased redness, watering, and difficulty in reading. The only bits that I could sort out was the redness and watering. Unfortunately, I could not change make a difference in difficulty in reading, because that was related to his glaucoma. I will quickly share one more case with you, and this is I was very concerned about this patient too. He currently is 25 years old, from Bengal, but he was given steroids for red eyes in the past, and he had advanced uncontrolled glaucoma, and I think he had JOAG as well. And he had TRAB MMC elsewhere. And when he presented to me, he had scarred blebs. And he presented 9 years ago with a vision of count fingers 2 meters and 20/100. In the left eye, he had very advanced glaucoma, and RD and lens aspiration was done, and he was controlled rising. So we started him on medication. In the right, transferal cyclophotocoagulation was done, and for a few months he was told, but he started to he was keen to pursue the same in his right eye. He was now an independent person, was working, and he was not dependent on his dad for funding him. So we planned for surgery, but he started complaining intense itching on the current medication. He sent me these photographs in the first pandemic. This is how he looked in April 2020. Obviously, it was a teleconsult. So we stopped the alpha adrenergic and continued the rest, but unfortunately, it did not change much. So it was likely alpha adrenergic allergy, but soon his pressure went out of control, and we start, just groping at things. I started pilocarpine. The symptoms improved, but unfortunately, the pressure did not, and Diamox was added, and pressure at this time was 30 and 12. Symptoms worsened yet again, and I suggested Lotipred because I was worried about steroid response also, and diagnosed that there was possibly a back allergy. And you can see a very horrifying 54 pressure in the right eye. I suggested a lens aspiration in the right eye with drainage device. He was not keen because of the pandemic and wanted to repeat TSCPC. So he traveled in late August. Again, he had red, itchy eyes. His vision had dropped in both eyes. 36 pressure in the right, 18 in the left. And this is how he looked. Not in June. Well, this was actually teleconsult, but on recent presentation, that was his other eye. So all topical medication was discontinued, and he was put on maximum dose of Diamox. I did a lens aspiration with IOL and TSCPC again. It was extremely painful for him this time for whatever reason, although he'd undergone before. And I put him on Saflotan S. And in September 2020, his vision was count fingers 20/100, pressure was 24 and 18. And this is the last photograph he sent me, November 2020. Locally in May 2021, his vision was count fingers 2 meters and 20/80 in the left eye. So I was happy that his vision had improved. His pressure was 15 and 17 on Saflotan S. And in the right eye, locally, he was started on brinzolamide and beta blocker, although I had sent him off on BKC-free brinzolamide that alone did not control pressure in the right eye. So I will end by summarizing, and it did take a minute or two extra, is that there is proven IOP lowering efficacy over 24 hours. And this is similar to other prostaglandin analogs where tafluprost is concerned. There is superior safety and tolerability to other PGAs. And the preservative-free Saflotan S should be used in severe ocular surface disease or back allergy. And all above factors should result in treatment persistence and patient adherence. And you need to watch the space for future development.